Hello, it's my pleasure to be here in Barcelona. I get some research support for Cachexia. I don't have personal financial interest. I work in St. Gallen, clinically inpatient, outpatient, with focus on palliative care and medical oncology. I'm chairing also the working group of palliative and supportive care. That's a typical patient who complains about perceived helplessness of the teams to help him, and also a helplessness of the wife, who does not know what to do, and the main problems are fatigue and appetite loss. So you are challenged how to help this patient. So the challenges we see in these patients are, shall I and how alleviate appetite loss? By good communication as a care specialist, or should I give drugs to alleviate appetite loss? Second question, shall I motivate this patient to do rehabilitation? And also a question, shall I feed these patients artificially? To solve this question, we need to understand what happens with this patient. So in this patient, there is cachexia, and cachexia is a multifactorial syndrome which focuses on the muscle. So the muscle decreases, and per definition, the muscle is not the muscle loss is not reversible per definition by nutrition alone. And what happens is a dual pathophysiology of decreased intake and abnormal metabolism. Now, if you look in the patient, you see that cachexia happens in the muscle, in the gut, in the brain, and in the catabolic compartments of the body. So in the stand cachexia, we have to understand the muscle is building itself away, so it's proteolytic, the synthesis is decreased, the guts are slow, and the brain has no signal to be hungry. And what happens, the patient has decreased function, he loses also physical activity. And on the left side you see what's driving cachexia. It's a tumor which is active. You see resting energy expand. The tumor is making the body being always active, even without mobility. And you can measure that also by pro-inflammatory cytokines. If you look at the muscle, you see these changes. You see on the left side a muscle in a cachectic patient where you see fat goes in the muscle. So by pro-catabolic, hypo-anabolic phenomena, the muscle changes itself, and that's cachexia. Now, cachexia can happen through the whole trajectory of cancer patients. You see patients can have pre-cachexia, that these mechanisms happen in the body of the patient. There's even data for neoadjuvant esophageal carcinoma patients where you have pre-cachexia. Then the full picture of cachexia with weight loss of 5% in 6 months. And close to end of life, you have refractory cachexia patients, which is per definition caused by the cancer, is pro-catabolic, and does not respond to anti-cancer treatment. Now, clinically, if you have a patient in front of you, the question is a patient more on the left side with anorexia, nutritional intake, autoimmune dysfunction, more on the right side with hypercatabolism, inflammation, cancer dynamic, hypo-anabolism, and these patients have then decline of neuromuscular function, loss of muscle mass, loss of muscle quality. Now in clinics, what a challenge is that you have also patients on the left side, patients who are close to malnutrition, and the challenge in daily practice is that patients can have also starvation. So a patient neglected for wrong diet, for constipation, bowel obstruction, uncontrolled symptoms, is a patient with malnutrition who might not have cachexia. And in clinical practice, that's very important. Also, patients can have sarcopenia due to other causes. So a patient can, being in bed, at bed rest, he can have hypogonadism, too long corticosteroids, thyroid dysfunction, or an elderly patient has age-related sarcopenia by mitochondrial dysfunction, by training does not hit in the fiber type 2, etc. So these patients co-occur in your practice. That's the situation of my patient. So understand the dual pathophysiology, the mix of starvation, sarcopenia due to other causes, and the question you will ask me now, does it matter, Dr. Strasser? Yes, it matters. You see, these are patients. We know that cachexia causes suffering of patients and family members, psychological distress, cachexia-related symptoms like breathlessness, fatigue, appetite loss, and also decreased physical function. Now, cachexia also matters for survival. We saw nice survival curves of Dr. Strasser. You see now, I want to mention that we do not have good data on direct or indirect costs of cachexia. So we don't know the financial impact of it. You saw from Dr. Strasser survival curves. Now, survival is caused by cachexia also. There is a lot of data that weight loss is correlated with decreased survival. Also a lot of data performance status. Now if you look closer and you combine weight loss with BMI, survival is bad. If you combine muscle mass alone, has impact on survival. If you combine muscle loss with muscle attenuation as a signal of pro-catabolic hypo-anabolic phenomenon, you have also survival decrease. And if you look at the inflammation only, CRP is linked to survival. If you combine albumin, also an acute phase protein and also a nutrient protein, you see also that survival is decreased. This is data of the modified Glasgow prognostic scale with CRP below and higher than 10, albumin below and higher than 35. You see the survival curves. All that together is survival relevant. Now, if you look at this is data from Lisa Martin just this year in JCO. We combine BMI, which is high or low, weight loss, which is high and low, then you see survival in months. Dr. Dicato has a good start if you would get cancer, because he has a BMI above 25. The challenge is to have a low BMI not to get cancer, but if you have it, to have it high. So this is the challenge in clinical practice. Now you can also look at the grading system, grade 0, 1, 2, and 3. This is survival curves. Now if you factor in this system also CRP, you see that the grade 1 cachectic weight loss and BMI low patient has, if he has a CRP lower than 10, 30 months. If you have CRP above 10, he has 7.7 months. So this supports the cachexia pathogenesis and convinces you about survival. Now if you look at the data in a different way and you have a threshold of weight loss, muscle loss and muscle attenuation, you see that if you have all three factors together on the right side, you have 8.5 months. If you have no of these factors, you have 35 months. And the more obese you are, the more relevant are these factors. So the third point why it impacts if you give anti-cancer treatment. If you have a cachectic patient, he has more toxicity. This is data from Vicky Barakos' slide, where you see dose-limiting toxicity in normal patients and sarcopenic patients. The bars, red, show more dose-limiting toxicity. The blue bars, no sarcopenia. So it really matters. And also it matters for surgery. There are also data, if you go with cachexia in a surgery, you have more complications and you have poorer rehabilitation. So what do you do in practice? You should find these patients. It's very simple. Ask them 4 questions. Number 1, do you have problems with eating? Number 2, are you tired? Number 4 and number 3, measure weight loss. And number 4, look for BMI. If you do this homework, you find those patients. They're abandoned in your practice. Then you can diagnose cachexia. Pre-cachexia, there's no standard yet, but my message is if you have a patient with physical fatigue, he might be pre-cachectic. If you have a patient who has 5% weight loss in 6 months, per definition, without fluid retention, he's a cachectic patient, or below BMI of 20 with a little bit less weight loss. Refractory cachexia, I showed you before the slide, there's no standard yet with modern oncology. What does it mean? No anti-cancer treatment option. This is difficult to define. Now, if you find your patients, what you do, you assess them. How you assess these patients? Spend a half an hour with these patients, alone or with a nutritionist. Look for weight loss. If the patient has fluid retention, you might do a CT scan or DEXA scan for muscle loss. Make a 2-day history of oral intake. Measure the protein intake. Many patients eat less protein than they should. Look for secondary nutrition impact symptoms such as constipation, such as nausea. And there are checklists for that, like a SNIS checklist or a PGSGA. Then talk with yourself as oncologists and ask the question, will my cancer be responsive to your next treatment? Measure CRP, measure albumin. And you get a hint if the patient is in a refractory phase or in a cachexia phase. And ask yourself, what is the KPS of the patient? Ask the patient itself. So these are the staging work you have to do. I recommend you to liaise with nutritionists and physiotherapists to this work. And then you decide on cachexia phase and goals of intervention. Now, what are the goals? If you are in pre-cachexia, you want to prevent. If you're in cachexia, you want to stabilize. If you're in refractory, you want to alleviate. So it's useless in a refractory patient to work for better function or increasing of weight. It doesn't work. But in the cachexia phase, it's worth to combine those things. And as a cancer supportive pelvic care specialist, I look also at the data of best supportive care and the early integrated palliative care, its important effects in the stabilization phase and of course close to end of life. This is a patient of mine from a couple of days ago. She's walking now around. Now the message was we had strong discussions. Is it worth Dr. Strasser to go on with eating, with walking, etc. for first-line invasive ductal carcinoma of the breast after 2 cycles, after 2 doses of Taxol, CA53 went down? Yes, it's worth, Mrs., because multimodal treatment works. That's your clinical situation. Now, this is multidimensional management. In cachectic patient, you have to combine those. Nutrition, activity, physically, disease coping, life goals, motivation, tumor control, if possible, and also anti-cachexia drugs. That's multimodal management. Now, as a pelvic care specialist already mentioned, a lot of that is integrated in probably early good palliative care or in best supportive care, and Yusuf Safar just talked, who is one of the main authors of these papers. I go now to nutrition. Nutrition is relatively simple because you have just to tell the patient the pathogenesis. Your guts are slow, so eat many meals, eat a lot of proteins, change your habits, and you have to be smarter than your brain. You have to make a conscious decision to eat even though you don't have appetite. So you have to educate your patients. That's the evidence. Now, what is the evidence? This is a study from Baldwin, who did a systematic review, meta-analysis of the data, and you see they found 13 RCTs, dietary advice, or oral nutritional supplements, or both. And for nutritional status, they found very significant improvement, but if you look at the statistics with heterogeneity, it's a little bit more challenging to interpret this data as a very clear signal to give only nutritional intervention to patients. If you look at treatment toxicity, 2 trials show no difference, but 5 studies are shown below. Early studies show that if you make better nutritional intake, you have less anti-cancer treatment toxicity. So it seems to work. Now also the question, should I give my patients pro-nutrition? Old evidence says don't do it. Current evidence, there is almost no prospective randomized trial. A new case series, I show you below, Oreval, Bozzetti, Kulin, Senese showed nice studies. I show you one study of this prospective case series from Bozzetti, and they looked at 440 patients prospectively studied. And interestingly, those patients who have a low Karnofsky have elevated CRP, low albumin, and metastatic. Guess what? They have cachexia. It doesn't work. So a patient who has mild cachexia, you could feed. If he has active cachexia, don't feed him. What I do in practice? I check for secondary causes. I try to decide if it's refractory. I make a nice decisional approach. I don't go into that today. I up-titrate the patient, continue oral intake. I define the goals with the patient, function, fatigue, symptoms, prealbumin, and I do weekly ask my nurses and the physiotherapist, does it work? That's the best we have at the moment. We wait for RCTs. Then, patient who has distress, we need to have a concept to diagnose distress of the patient, distress of the wife or the man, and the couple distress. The main point is that you say, did you experience stress because of eating? You did the most important thing, you diagnosed it. And then there are strategies to alleviate it. Most of the time we just do education to let people understand. Then I prescribe physical activity. That's also very simple. You prescribe on a receipt sheet 3 times a week, walk 10 to 15 minutes, and do 2 to 3 times a week, something here, something here. The evidence is more or less not very good, but there are also some trends that it works. And I show you one study, unsystematic review from Gurastene, who showed that if you combine aerobic exercise with resistance exercise, it might be probably better than doing just aerobic exercise alone. So the message is only walking doesn't work, only weightlifting doesn't work, make a combination. That means in practice you should bring your physiotherapist to your patient and let them teach the patients these combinations of it. Then you have also to talk about misconceptions. Many patients have misconceptions. Resting and sleeping will help muscle to recover. Who did not hear that message? Tell them what is cachexia. And also physical activity will absorb too much energy. You learned that sarcopenia can be caused by bed rest. So if you don't use your muscles, you have sarcopenia. And so these are very important educational parts for your patients. Educate your patients. Then you are doctors and other professionals here. So what are the drugs? Many of us like to use corticosteroids, but they work only for appetite, only for 1 to 2 weeks. There are 2 recent placebo-controlled trials from Jennu and also from Oldenhof Poulsen from Norway, and they show that for 7 days or for 14 days they improve fatigue and anorexia. Wonderful. They make side effects of myopathy, candidiasis, depression, anxiety sometimes. Now importantly, corticosteroids are not cachexia drugs. They are short-term marriage or have a nice weekend drugs, but not for cachexia. Progestins are also working, many, normally 3 to 4, but only fluid or mass, no better quality of life and make side effects. What I use very often are prokinetics because autonomic dysfunction, early satiety. So in summary, if you have a patient who has short-term, you want to increase his appetite, his fatigue, give him steroids for 1 week and stop it again. Progestins very rarely to give because you make thromboembolic events, and prokinetics, almost every patient gets it, but the evidence is scarce. Then the drugs who have insufficient evidence at the moment are cannabinoids, where you have the combination of the plants and tronabinol. A recent trial shows that patients who have dysgeusia, it might help. Fish oil are 3 scientific reviews negative, and small trials show that it might work. So the better designed the trial is, the more potential it might have. NSAR, as a non-steroidal aromatics, is also insufficient evidence. They have not been used in bigger trials or only in combinations. So we don't really know if it works or not. Then what we have, an exciting time. We have many new drugs which are emerging. So we have the MC4 antagonists, which are maybe a little bit disappointing because the oral intake is not very easy of those. Then ghrelin, I'll show you 2 slides on that. Ghrelin is a natural hormone which your stomach produces, which makes effects on anabolism, on appetite, also a little bit anti-inflammatory. Androgens, selective endocrine receptor modulators, enobosarm has 2 trials finished, which increase muscle mass, associated with increased stair climb power and fat, but goes fat down. So you build muscles, but your fat goes down. Myostatin pathway drugs are underway in phase 2. Inhibitory drugs, anti-L1 is promising. In the Lancet Oncology of phase 1, which is very promising, and also many other promises. If you want to listen to promises, come to Paris, beginning of December, where you have all the exciting cachexia drugs, all the exciting cachexia community. Now, Emeralin, I give you 2 slides. There are phase 2 trials with multiple cancer types showing a lot of endpoints better. Now we have Romana 1 and 2 trials, which are presented by Jennifer Temal at ASCO and last September in Madrid on the ESMO. And there were 2 co-primary endpoints, muscle mass and hand grip strength, and muscle mass increased, hand grip strength not. Secondary endpoints, fat mass increased, cachexia-related quality of life improved, fatigue improved, and toxicity was mild, hyperglycemia, survival data are similar. So we have a drug which might be in the future in our hands. This is 1 slide with all the data, so with almost all data. So in summary, stores, muscle increases, fat increases, muscle strength, it doesn't improve on the muscle, on the hand grip, but legs and activity were not measured. Symptoms you see, fat improves, fatigue improves, but toxicity was not measured. That's the data. Now we come to the end on multimodal interventions. There's a study which have been shown at ASCO where we combine exercise, nutrition, and anti-inflammatory medication, non-steroidal aromatics, and EPA in a very concrete combination, as I showed you before, patient with lung or pancreatic cancer, and the outcome is feasibility only, compliance, enrollment, and also secondary endpoints. So you see, as I said before, aerobic and resistance training, nutrition with proteins, and something anti-inflammatory. This is the data. You see 80% compliance on NSAIDs, on nutrition supplements, moderate compliance, exercise about 50%, but 80% of the compliance. The weight data are significant, but this was the question for a phase 2. They're encouraging. We are now in a phase 2, in a phase 3. And if you're interested in a phase 3, give me a mail and you can be enrolled. So in summary, cachexia is a multifactorial syndrome, often hidden under physical fatigue. You need to do routine screening every patient in regular intervals. and the ESMA guidelines will come out soon. A strategy is a combination strategy, and you should look for mechanism-based intervention, nutrition, activity, and in the future also targeted drugs. And the last message, we need to do multi-professional interdisciplinary work together with all these people. We need new drugs, and promises are here. Thank you very much.